So it's my distinct pleasure to be able to introduce Dr. John Halamka, and he and I are going to have a fireside chat for about the next half hour. And John is president of the Mayo Clinic platform, but that's a relatively recent role, and we'll get into that. But prior to joining Mayo Clinic, John was executive director of the Healthcare Technology Center for the BI, Beth Israel in Boston, and was formerly chief information officer at Beth Israel, and was also a chair professor at Harvard Medical School. I want to dig in a little bit to this role for innovation at Beth Israel. John oversaw the digital health relationships with industry, academia, and government worldwide. And with his government roles, served in both academia, served in both the Bush administration and the Obama administration, and governments around the world planning healthcare IT strategies. And in addition, was responsible at BI for clinical, financial, administrative, and academic IT. And I think that arc is really important because it goes to not only the kind of billing thing that EHR systems, electronic healthcare record systems, originated in, but also gets into the care delivery domains. As I said, Dr. Halamka is relatively new to Mayo Clinic, but if you saw Peter's talk earlier in this sort of hunt for platform talent, I think he represents exactly the type of experienced hire that you would expect incumbent organizations to start to seek as they try to figure out people who can kind of span these boundaries and manage all of these external relationships. And a surprising fact is that in addition to what you would view as at least one or two full-time jobs, John is also a practicing emergency physician, and I believe sees something on the order of 900 patients per year, at least the last time we spoke. So John, thank you so much for joining us here.
Well, absolutely, and welcome to the Unity Farm Library, where I am socially distancing, but on Zoom 16 hours a day.
you and me both. I'm trying to figure out how we can be even busier in this time of lockdown. It seems maybe there was a lot of downtime in the traveling and the moving around that we've now just filled and plugged in the holes.
Exactly.
So we met about 6 months ago, give or take, and the world has obviously changed a great deal in the prior 6 months. So I have a series of things that I want to explore around platforms. But before we get to that, maybe just tell us a little bit about your role in the COVID response, because I think that's ended up really spanning some pretty interesting ground.
Well, certainly. And so, as you say, I joined Mayo Clinic in January and was charged with bringing together a variety of digital businesses and storage and compute and alliances and all the rest. And then COVID happened. Yes. And of course, you asked the question, imagine that COVID has 5 stages. Isolation. We're wearing masks in our homes, Zooming. We then get into more of we start to go out. We need testing. And we need contact tracing, figuring out who you touched and who got infected, and isolation there. And then you're going to have this return to work, what we'll call pre-vaccine period. And then maybe the return to work post-vaccine period in the new normal. And so if you look at those 5 stages, think about all the organizations needed to provide all the platform services across those 5 elements, right? PPE is all about supply chain platforms, or ventilators, coordinating manufacturing, or cures, figuring out what drugs work and not, and all the data on efficacy, right? Does an antimalarial drug work or not? And vaccines, which vaccines, and when are they safe and efficacious? So to do that, you really need a coalition. And so it was about 12 weeks ago that it seemed that there were a variety of private sector companies, and this would be Google, Microsoft, Amazon, Apple, right? Many companies coming together and say, how do we help if we're going to provide all the platform services across these 5 stages? And we formed a completely nonprofit, completely selfless, no one is, in a steering role here, a coalition called the COVID-19 Healthcare Coalition. You'll find it on the web. at C19HCC.org, COVID-19 Healthcare Coalition.org. Every day we post 700 data sets, and you'll see it's situational awareness for when should you open or not, and how is a county level trend going in the United States. Oh, what masks work and don't. How many ventilators are you going to need next week, right? And all of this is a set of platform tools, cloud hosted and provisioned by all these federated organizations working together. And maybe one last thing to say, and then of course there have been many coalitions founded, as you've probably seen. So we formed a coalition of coalitions. So all the platforms could be together, and you'll find a website called thefightisininus.org, where we've got The Rock, Dwayne Johnson, Samuel L. Jackson, Helen Mirren, and a variety of other celebrities who are the voice of this coalition of coalitions, all running a plasma bot platform, encouraging donations and trying to get to cures as fast as we can, all using a platform approach.
So I love that coalition of coalitions description. And actually, I'd suggest that we're likely to see that in a lot of contexts. You know, from industry, we saw that from Siemens this morning, and Dr. Bush's presentation. So I just love the metaphor. So first of all, a little tech support. They've asked you to turn your volume down slightly because we're getting a little feedback. So, you know, one of the things that I've heard repeatedly when I speak with companies, especially over the last couple of months, and the pandemic, is this notion that we've had 5 years of change in either 5 weeks or in a couple of months, or 5 or 10 years of change. And you just described this coalition of partners, technology companies, and you're working with governments. Would you say that the pandemic has made those relationships sort of easier to pursue and just out of necessity? And do you think that those changes are likely to endure, or once this passes, we'll all kind of go into our separate corners and then wall ourselves off from one another?
Well, what a great question. I've turned my volume down, so hopefully less feedback. So I've been in this industry for almost 40 years. And everyone said, oh, you know, we're going to get to this virtual, connected. Patients are going to be using their phones to contact their doctors and upload their data. We'll have wearables. It'll all be wonderful. And of course, we said, and by 2030, we'll have this. Well, guess what? From January through about March of 2020, we made that transition. and simply because we were no longer able to have these on-premise visits, we had to go through virtual care delivery, and that spanned everything from asynchronous store and forward of pictures that you take, to virtual consultations, to acute care in the home. Yesterday, Mayo Clinic went live with hospital at home. We're treating patients now as our Florida campus with COPD, congestive heart failure, kidney failure in their homes with remote patient monitors and teleconsultation and nursing. And so I tell you all that because, well, what happened over these last 12 weeks? Regulatory waivers. There is no longer a need for John, who's licensed in Massachusetts, to have a license in Florida, right? It's no problem. I can do my teleconsultations anywhere. Reimbursement has changed. There's now parity between what I used to get for an office visit and what I get for a phone call. And there's every single day, all these restrictions on credentialing and who can do what and what site of service is appropriate, and can a paramedic actually come and work in your home as opposed to taking you to a hospital. It's all changed. And so what is going to happen, to your question? Well, I've talked to CMS, I've talked to HHS, FDA, and they all say the same thing. Don't roll back. This virtual care and the platforms associated with it is the new normal.
So I love that answer, and I hope that actually maintains. And I imagine that there will be some forces but trying to return. So that'll probably take some diligence to pull off. And you kind of mentioned all the things that I was expecting on the regulatory changes. And just as a sidebar, you mentioned PPE and the coalitions of companies that rapidly produce that equipment got waivers from antitrust authorities to be allowed to cooperate. And so similarly, we're able to get some pretty quick things happening. Um, I hadn't really thought about the reimbursement issue, but of course it makes perfect sense that if you can get parity, then you can make people much more willing on the provider side to do these innovative sort of solutions. So one question I would have is where where do you think you're giving up quality, if you will? I mean, you said you're able to do some pretty interesting interventions remotely. And on the flip side, where do you think things might actually have improved in our ability to do these remote consultations and interactions as a caregiver and with patients?
Sure. So let me start with the second question first, because the quality question that's a little harder. So let's imagine the customer experience, right? Here we're MIT Platform Strategy Summit, where everybody is a UX and customer experience expert. Let's see. Now, Jeff, you're in Massachusetts, right?
New Hampshire, but pretty
New
close.
Hampshire. Okay. So imagine you from your location had to drive to Boston in a non-COVID time. How long would it take?
Longer.
Well, yeah, and so the answer is, let's see, your usual experience is that you're going to go see your doctor for 15 minutes. You're going to drive 2 hours. You're going to pay $40 for parking. You're going to sit in a waiting room with people coughing on you. And then you're going to have a 15-minute encounter, and then you're going to go on a 2-hour on the road, hit rush hour, nightmare. Well, imagine I could deliver the exact same experience with the exact same outcome in real time with no travel at lower cost. Like, okay. So, what we're finding is the number of sensors that are evolving in the market is so significant that, of course, we can measure pulse and blood pressure, pulse oximetry, but there are even companies developing remote urinalysis diagnostic sensors for the home. Or one that I was chatting with yesterday has developed, we'll call it it's like a heart EKG, but it's for your abdomen. And imagine you have ulcerative colitis or Crohn's disease or some issue of the abdomen. In effect, you put a sensor on your abdomen and it does an electrical signal analysis in real time of your gut motility. It's like, okay, well, so start asking yourself the question, like, what can't we measure remotely in a consumer's location at low cost? Well, admittedly, physical examination, is harder at a distance. But again, I'm going to push back on that. So I went to medical school in the 1980s. And, papers published since then have suggested that the sensitivity and specificity of the physical exam is just not so good. So if I can get real-time digital telemetry, I may not be giving up much. And maybe the last thing I'll say is it's a kind of cultural question for you, which is my mom is just about 80. And of course, she for her whole life has gone to see a human. And it's been a very tactile experience. And so the question is, well, does she feel like she's lost something like empathy because you don't have a human who's there in a room to hug you, touch you or reassure you? Okay, I think that's probably true. But my daughter, who's 27, has never had an expectation of a not digital experience and is completely cool with quality care delivered instantaneously at a distance. So we'll answer your quality question by it kind of depends a bit on your expectations. But in terms of being able to do remote diagnosis and treatment, I don't think we're giving up anything.
That one I think we could probe, and I have to agree with you a lot. And I love the sensor question. And as sort of this Internet of Things gets cheaper and cheaper, then we can instrument more and more. I imagine my imaging colleagues would say, "Oh, but wait, what about the nuclear sort of imaging machines and the X-rays, and you say, well, we're getting there maybe, but probably the ultrasound units are starting to get a little cheaper. Um, so I, I asked a question early on when I asked you to do this, and I said, Mayo's been operating since 1864. So it's been around for a long time, and the pace of change was already rapid, just as a result of mega trends. And so maybe talk a little bit, knowing that you're new to the organization, but how are you seeing their adaptation to this? You have a kind of a complex machine that has a lot of routines and a lot of moving parts, being really stressed, not just by COVID, but really by the changes in the whole healthcare and technology landscape writ large.
Well, sure. So if you read the history of Mayo Clinic, and really quick, when you become a Mayo Clinic employee, you are given the history of Mayo Clinic, which describes exactly what Mayo did to be an innovator over the last 150 years. And that includes, it invented the medical record as we know it. Now, here's the problem, of course. It's 1880, and you have to have a cloud. Well, what are you going to do? Well, of course, Henry Plummer invented, in effect, the Mayo Clinic cloud by creating a network of pneumatic tubes and conveyor belts so that any patient going to any destination to see any provider would instantaneously have all their information available to them. And this was a innovation revolution, because the problem is every doctor used to have a notebook and used to write the patient data, and it would be siloed. So in effect, we've been doing a cloud and distribution of data for 150 years. All we did was go from analog to digital. And I think the major adaptation is that Mayo did a partnership agreement with Google, 10-year partnership, where Google and Mayo work together on very large scale storage, compute, AI factory, data ingestion and orchestration, using a whole variety of collaborators and tools. And so what you've seen is, whenever you do a transformation like that, you need a visionary CEO. And the CEO of Mayo, who's been there 1 year longer than me, Gianrico Ferrugia, was hired because he said, we're going to be a platform-based organization. And that what we're going to do is think about how we're going to, by 2030 was his notion, deliver large-scale data analytics and AI, democratized to the world. Remote care, even high acuity care. And this is going to be a series of components that we build and buy and assemble into various platform businesses. Well, again, that's the 2030 goal. Well, remember I said things have happened over the last 12 weeks to slightly accelerate that. We're already live with a whole bunch of this stuff. And the Mayo Clinic organization culturally has embraced it. And the comments they're making is delivering high acuity care in a patient's home using remote patient monitoring and virtual visits is no question the future evolution of what we've done for 150 years. So I actually see this is just continuing what we've already done. It isn't necessarily a sea change.
It's fascinating. I was fortunate enough a little over a year ago to get to meet Gianrico and give a talk at Mayo, and he told me that there was this 10-year plan, which was, we're going to talk about platforms for the next 10 years, and what you've told me is that 10 years turned into 10 months, perhaps.
But you made an interesting comment when we first started about recruitment. And let me just comment on that, because we're in a platform summit.
Yeah.
So when Gianrico talked to you, he said, we need a leader for this platform adventure. And so they wrote a job description. I don't know if you've seen it. Must be a physician, MIT Course 6 trained engineer with 30 years of digital transformation experience, international travel, and extensive communication. So, of course, the phenotype of this particular job description was 1, 2, right? And so they were kind of brilliant, because here I was an endowed Harvard chair, right? And why would you leave an endowed Harvard chair position? And the answer is quite simple, which is they created this platform concept where the CEO and the board of directors said, we're going to change healthcare in the world by bringing together all these digital capabilities. All we need is somebody who will have the engineering and medical expertise to help us on that journey. So I think more and more recruits, to your point, are going to be moving into platform-based positions. It just does require slightly esoteric experience.
Well, and I think for the first movers, in particular incumbents, they're able to kind of define who it is that they want and then offer the inducements. It'll be interesting to see how firms, as Peter said earlier, grow their own talent internally when those aren't necessarily available. And I'd actually ask the complementary question: what do you wish that your colleagues at Mayo knew about IT, about EHRs, about EMRs that would help you be more effective in executing sort of this platform vision that's emerging?
Well, I'm not sure there's anything that I would regret or anything that I feel is a negative, but I will tell you this: when we put the platform strategic plan together, we said we're going to have an 80% failure rate, right? And this is like completely novel to Mayo Clinic. What? We're going to fail? And I said, look, right? I mean, we don't know what the platform in healthcare is going to look like in 5 years. Maybe we don't even know what it is in 6 quarters. So, but we got to try, right? So we have to deal with, can we do remote diagnosis from your Apple Watch? Maybe yes, maybe no. Try it. Can we develop a warehouse of algorithms that the world would connect to? So it isn't just Mayo patients, right? It's anyone. Maybe, I don't know, let's try it, right? And so what the board and the Mayo Clinic staff agreed is that the only way we could try to be a category of one is by testing out so many speculative things, taking risks, and being given the freedom to fail. And that is entirely novel to Mayo Clinic.
It's entirely novel, honestly, in sort of traditional business, because that exact thing that you just highlighted would be a root failure at numerous companies, where they want a detailed plan with financials before they even necessarily know a successful use case and iterated.
Yeah, but here's a quick example for you. And believe me, I have no association with any company, so I just highlight this. So I'm going to take off my glasses, and these are the Amazon Alexa glasses prototype, part of their Day Zero program. They expect it to fail. But their notion is probably we will want wearable computing of some kind. So let's try something and let's see how it works, right? So I now have a full Alexa implementation on my face. And that means it turns out at my farm, I have 103 Internet of Things devices, and I can now control all of them with my glasses. Right? I mean, good or bad, right? But I mean, I can change the temperature, turn on and off lights, unlock doors, whatever, right? Do you want it? Is there a market? I don't know. But boy, it's worth a try.
Yep. Well, so I'm going to shift because while we were talking, quite a few questions have come in from the audience. So I want to make this participative. So please keep adding questions. But one really resonates here, which is how do you think about training and educating patients and family caregivers to be better at this sort of co-production, if you will, of healthcare and telemedicine at home? Because presumably, that shifts more and more of the responsibility onto the patient and home environment.
Right. So I'll answer it in a couple of ways. So first, it's really important when we're on this topic to talk about the digital divide and talk about equity and talk about ensuring that we are meeting the patient at their level of technological comfort. So when I think of platforms, I don't assume everyone's going to have an iPhone 11, right? Everyone's going to buy an Apple Watch, right? You can't, right? You have to ask yourself, what do your patients expect? And there are going to be those with Nokia flip phones, and you got to respect and support them, and those who are wearing Alexa on their face. And okay, right? So meet the patients where they are with a spectrum of end user customer experiences. But as well, I think that so much of our remote care is going to depend upon not just objective data, the sensors we talked about, but subjective data. What is your pain score? Something I can't measure so easily. How do you feel today? And so one of the things we are thinking about as we develop these platforms is the nature of the data we'll ingest. We'll take many participatory contributions from patients and their families. And I mean, even things like social determinants of health, right? It's hard to actually get that in a 5-minute encounter with a registration clerk. But if you're asking a patient and family to interact in a participatory fashion with the record and their experience and provide you more detail, you can better tailor care to their needs. So there's no question. Patient contributed data and meeting the patient at their level of comfort are two key focuses.
So I love the sort of technology question, but I want to push a little bit harder on that because a number of questions have come in around two-class systems. So you talked about digital divide, but we don't necessarily have a solution. Are there ways that through this platform sort of group of partners, there might be, for example, centers that you could go to that have good connectivity and technology so that you could drive within 5 or 10 miles as opposed to the 2-hour drive down to Boston that you described earlier?
Yeah, so a couple of ideas here. So Zach Kohane at Harvard, who has been a close friend for many years, did a study some years ago looking at the capacity of Medicaid patients to receive a text.
Mm-hmm.
Right? And it turns out actually 80% of Medicaid patients and their families can receive a text. So you say, aha, requiring everybody to have, iPhone 11s with apps. No. But if you engineer to say, if you have that, fine, but a text will support a whole lot of people. And you don't even have an internet connection or a phone plan, that's okay. You could imagine that there, as you say, it's the library, it's a workplace, it's a place you could go for an intermediate connection to your healthcare giver. But I imagine it's going to be a little strange that we're going to end up with a new class of medical provider, a care navigator, or call it a care traffic controller. And here's the quick comment I'll make. My mom, when I told her, do you know there are Fire-enabled APIs that enable you to download your full data set and manage it on your phone? She said, I don't have a clue what you're saying, but I'm more than happy to delegate to you to be my care navigator. So I think your point's well taken. It's let's engineer to appropriate levels of comfort, but let's also think about the necessary personnel who might be an intermediary, an interpreter, and navigator for those who have no digital access.
Yeah, I love that notion of the intermediary because, of course, that helps with reducing friction and improving access and people's willingness to participate in these systems. One thing that I'm actually going to ask the final two questions. One is this issue of interoperability of data types, and I know that you've got a big tech partnership with Google, but sort of talk about that a little bit and how you're beating down some of these silos. And then the second question is, what you're doing here in the US, how would you see that as going global? Maybe answer the second one first, because
okay, sure. Well, these are both excellent questions. So for the last decade, I've worked with the Gates Foundation.
Mm-hmm.
Spent a lot of time in sub-Saharan Africa and India. And so it turns out, as you point out, globally, right, there are issues in each location. So let's take India. It turns out the per capita income in the towns I work in, like, Bihar State and Patna, per capita income is $1 a day. But yet everyone has a 4G Android phone and a SIM card that enables them to get a fair amount of data, right? So, okay, can you deliver a telemedicine experience even in a place that doesn't necessarily have access to clinical care? The answer is yes. And so the Gates Foundation has funded quite a lot of this telemedicine delivery to resource poor areas. But then you get to sub-Saharan Africa, and they don't have a lot of bandwidth. Bandwidth's expensive, and they're often community healthcare workers who have a phone. And you have to build a store and forward mechanism because they don't necessarily have phone connectivity while they're in a village. And so you engineer again to the sort of cultural and technological capabilities of a region. But nonetheless, this notion of a cloud with hosted services that are accessed by someone, whether it's store and forward or direct connect, has worked worldwide. Interoperability. So remember, there are two rules that have been finalized by HHS and ONC: the interoperability rule, the information blocking rule. Basically, what it says is every provider organization must make available an API for every patient to access a set of common data elements, and you cannot say no. So some of this was technology, some of it was policy, and now sort of the last bit, some of it's psychiatry. People who just don't want to share, it's now a federal law.
So I think that's a great place to close on, John. I feel like we just got going, and I could talk with you for another hour. However, we're at the top of the hour, and I would just like to thank you so much for sharing a little bit of your time and your experience. Hopefully, we can continue the conversation, because I suspect that you're going to have a wild ride over the next 12 months.
Agreed. Well, thanks so much, folks. You have a great afternoon.